I'm Dijo Susilo, co-applicant of STAN Indonesia. I will be presenting the findings from our survey STAN Indonesia on the prevalence and factors associated with mental health disorders among Indonesian. Next, please. The background on why we conducted this study was because of concerns on rising mental health disorders. Depression and anxiety increased more than 25% in the first year of the COVID-19 pandemic. And 1 in 8 people, or around 970 million of world's population in 2019, live with mental disorders, where depression and anxiety rank the highest one. In Indonesia, based on Indonesia's Basic Health Research, or Riskesdas 2018, estimated that Indonesians aged 15 years and older, of more than 19 million people experience emotional disorder, and more than 12 million people experience depression. In comparison with Riskesdas 2013, there is an increase of Indonesians with emotional disorder from 6% to 9.8%. There was no study that measured both depression and anxiety in Indonesia, even though Riskesdas only measures emotional disorder and depression. Next, please. Yeah. So the effect of poor mental health are global economic losses and reduced productivity. It is estimated that the economic loss reaches up to 2 and to 5 trillion US dollar per year in 2010, and the loss is predicted to increase to 6 trillion US dollar by 2030. In Indonesia, anxiety and depression are estimated to cost around 4.2 trillion rupiah, or 297 million US dollar, and 18.9 trillion rupiah, or 1.3 billion US dollar respectively per year in 2018. For health facilities, up to the end of 2022, we have 10,320 primary health care centers or puskesmas in Indonesia. However, only half of them provide mental health services. And then for the hospital, up to the end of 2022, there are 4 provinces that did not have a mental health hospital, and around 60% of public hospitals we are not yet equipped with mental health service facilities. Furthermore, the number of psychiatrists in Indonesia is still very limited, with uneven distribution, as it is still concentrated in big cities. The ratio of psychiatrists to the population is 1 to 200,000. That is still far from the WHO standard, which is ideally 1 to 30,000 population. For this reason, it is necessary to know the determinants of depression and anxiety to reduce their prevalence. Next. So this is about the STAN, our project STAN Indonesia comes in. So STAN is the abbreviation of Sustainable Treatment and Care for Anxiety and Depression. STAN Indonesia aims to improve individual and population health outcomes in Indonesia by boosting equitable access to sustainable, evidence-based treatments for depression and anxiety. The program is funded by NIHR Global Health Research. It builds on strong partnership between the University of Manchester and Indonesia, which have been developed over 8 years. STAN Indonesia is supported by the Universitas Indonesia, National Research and Innovation Agency, or BRIN, and the directors of mental health and primary care in Indonesia. So our program is designed to mimic the WHO framework of action for strengthening health system. We have 5 work packages, as mentioned before by Ibu Santi, that the first work package about health information and data gathering. The second about health product or technology development. The work package 3, service support and workforce resource. Work packet 4, accessibility, high quality service delivery. And the work packet 5, sustainability and financing. As we do have also 2 cross-cutting terms, community engagement and partnership working, as well as leadership and capacity building, which is the one we are currently doing. So next, please, the aim of our study as done in work package 1 is to collect evidence-based data, where we aim to identify the number of people in the survey sites that have anxiety and or depression. We also need to determine the risk factors of anxiety and depression, as well as to provide information on healthcare utilization and the unmet need of people with anxiety and depression. After we have this evidence-based data, it will be used to it will be used in work package 4 to develop and implement low-intensity psychological intervention for people with anxiety and depression. So our survey was conducted in 12 sites at the Java Island from July 27 to October 20 last year, at 4 provinces, Banten, West Java, Central Java, and East Java, and at 6 districts of Tangerang City, Semarang City, Jombang District, Bogor District, Magelang District, and Malang District, with an even village sampling of 6 rural and 6 urban. The urban village are Cipadu in Tangerang, Gunung Bunder in Bogor, Bandar Harjo and Bululor in Semarang, Borobudur in Magelang, and Dukuh Kelopo in Jombang. Meanwhile, the rural villages are Gunung Bunder 2 and Cibunian in Bogor, Treko in Magelang, Sumber Aji in Jombang, Kasembon and Karangsari in Malang District. So for the questions we use to measure mental health disorder for anxiety is by the use of questions from generalized anxiety disorder or GAD-7. And for depression, we use questions from the Center for Epidemiological Studies Depression or CESD-10. GAD-7 asks how respondents were feeling on things that with a time frame of only 2 weeks, with score accumulated and categorized into having no anxiety, with moderate, and up to having severe anxiety. So for the cut-off score, for 0 to 4, no anxiety, 5 to 9, mild anxiety, 10 to 14, moderate anxiety, and 15 to 21, severe anxiety. For depression, the depression, the time frame of questions asked on how respondents were feeling during the past week. However, if the score accumulated to more than 10, then the person is categorized to having depression. Next, please. For all statistical analysis, we summarize the participant characteristics using mean and standard deviation for continuous variables and number for categorical variables. The association of socio-demographics factors with mental health disorders was determined using logistic regression models adjusted for age and gender. Odds ratio and 95% confidence intervals were reported, and we are using the Stata 18 to estimate the models. So here the result from our study. We are able to get 19,236 individuals from 8,586 households. And from one site to another, it ranges around 1,600 individuals, with the number of households varying but sticking around 600 to 800. We had targeted to get 1,600 individuals per site. However, for Sumber Aji and Treco, the number of people aged 18 years and older that were to be respondents did not reach up to the target. Thus, we took respondents from the village precisely beside it. So just next to the village with the same culture and etc. Next, please. The distribution based on sex and age groups is pretty evenly spread out, where the number of female respondents is around 10,500 respondents and having 8,600 male respondents. Next, please. So based on the employment, there is a significant difference between male and female, where most females are housewives in the survey, and males were mainly casual workers. Next, please. Based on marital status and education, 74% respondents were married and 14.4% were single, where for education, 44.6 respondents had an education on the level of primary and lower. Based on health insurance ownership, both rural and urban villages had the highest percentage of owning JKN or BPJS. However, in the rural village, we can see that only 46% of respondents did not have health insurance. Next, please. So this is the distribution of anxiety and depression based off the study sites. That the total respondent with anxiety is 12.17%, and respondents with depression is 4.42%. The highest village with anxiety is Banda Harjo in Semarang City at 67%, and for depression is Karangsari in Malang District at 9.51%. But we can also see that Karangsari is the second highest village with anxiety at 17.45%. And then the second village with the highest depression is Kasembon at 8.89%, where both Karangsari and Kasembon are located in the Malang district. Next, please. Based on urban and rural, the distribution of anxiety and depression can be seen that the numbers are quite evenly spread out. For depression status, for example, is almost the same, around 4%. For anxiety status, around 12%. And for depression and anxiety status, around 3%. Next, please. And this is the simple logistic regression model that we did to see the association of several factors towards anxiety and depression. So the logistic and regression models adjusted for age and gender. And we can see that those aged older had a lower risk of having anxiety and depression. Females are more likely to be depressed and anxious compared to males. And this is maybe attention for jombloers and jomblowati, that being married, you will have a lower chances of being depressed and anxious. And if you had a job, you would be less likely to be depressed or anxious. And but if you had comorbidities, you are more likely to be depressed when you are anxious. Next, please. So, in conclusion, the prevalence of depression and anxiety in 12 study sites in Indonesia was 4.42% and 12.70% respectively. being older, married, and having employment were associated with lower risk of mental health disorders, while being female and having comorbidities was associated with higher risk of mental health disorder. That concludes my presentation. Thank you very much.
So I'm also part of the STAN team, and one of the areas that I'm working in particular is about the economic sustainability and the equitable scale-up of services that also that lead us to the topic of this presentation. So I'm not an expert on Indonesia. I'm learning a lot, but I understand that there's an audience predominantly from there. So I've decided to then focus the presentation mainly on some thoughts that we started having when we started to explore the possibility of using the BPJS dataset to inform the allocation of resources and to inform some plan to scale up the provision of mental health services that we are covering in this project. So what I'm going to do is I'm going to present something very briefly and by no means with claim of being an exhaustive overview, some approaches to resource planning, some reflection on the use of administrative data for resource planning. And I will also give some example, but predominantly I'll give an example on mental health, on what that has been done for mental health planning in England. And I'll give some example of what the BPJS data contains. And this work has been mainly done by Dr. Alfariani Fatima, who's also a colleague from Manchester involved in the STAND project and is here in the seminar, and then conclude with some reflection on the potential and challenges of using this data set for some of the resource planning. So when we talk about resource planning, we basically intend to refer to those planning activities that are monitorable with a timetable and schedules for the implementation of some activities that have been preset. And there's a general agreement that the more complex and contentious side of planning is the allocative planning, the making of decision on how resources should be spent. And when we think about resources, those could be financial resources or could be human resources, but that often end up being simplified in money term as a way to have a measure that can be representative of different types of resources. And also, very broadly speaking, the objective of resource planning in the health sector is to promote population health, enhance equity and efficiency. And this is quite common across different countries where government play an important role in collecting, pooling, and then allocating different resources for the provision of health services. Objectives remain, at least on paper, the same. And one important thing that might differ in the way in which things are done across country is that resource planning and allocation would tend to be ideally evidence-based, but the extent to which this can be done is also related to the availability of different data sets. So we can think of resource allocation as one part in the whole health financing functions that government carry out. And that can be thought as a part of pooling or resources. So once resources are collected, how they're joined up either at the central level by the national government or at the local level by local government, or maybe directly at the provider level. Or we can think about resource allocation more directly as the way in which those resources, once they've been joined up, they are allocated either to local government or providers. So the framework here shows in a very simplified way, how generally resources came from the citizen and are either pooled to the level of national government, local government, or directly to services provided, depending on where the resources are gathered to provide care services through general or local taxation or through user fees. And then in blue, you can see where the summer resource allocation decision that take place. And this is generally when national governments allocate resources to local governments or directly to service provider when they're maybe more specialized or there's less provider. And there's also a resource allocation decision that take place when local government allocate funding to providers. And the decision typically are taken around where to allocate those funds, to which type of services to allocate those funds, so being that mental health or other services, or within mental health services specifically, which type of services and provided in which ways, and then to which provider, so being that, for example, more specialized provider or community services provider. So all of those decisions need to be taken at some point. And very broadly speaking, there's two different types of economic methods that can guide resource allocation. One is the economic evaluation tools, which are generally used to determine which health benefits, packages, or services should be funded. This is about, again, which type of services is generally more cost effective to provide compare to other. And those economic evaluation tools comprise different types of technical tools, including cost benefits analysis, cost effectiveness analysis, and so on. Another type of tool are the very broadly speaking, resource allocation formula. And this tends to be more concerned on how to distribute resources that have been set for a given set of services. And the idea is that those formula can inform the allocation of funding to subnational units or providers. And those formula are generally used to break some inertia that isn't coming through in the budget process, whereby there's a tendency to maybe keep allocating the same budget as the previous year to either provider or national government. And they often, in the majority of cases, when they use, tend to be, or at least claim that they aim to be needs-based. So they aim to be equitable and to allocate more resources where the need for services is higher. There's a bit of history in terms of resource allocation formula, and they're not only used within the health sector, but they're generally used within public services more in general. But the first prominent example of use within the public health sector goes back to the Resource Allocation Working Party in England in 1976, whereby the Working Party proposed for the first time to use a formula with the objective of achieving equal opportunity of access to healthcare for people at equal risk. And again, broadly speaking, this is the type of objective that we can see is still remain in place today for many of the countries that use a formula. At the time, the first formula was just based on population size, on the demographic profile, and on some measure of the burden of disease in different areas. That was approximated in a very simple way, but standardized mortality rate. And then as time went on, more data became available, the method becomes more complex, included more variable, accounted for socioeconomic status, and so on. And nowadays, for example, all of those models are based on patient-level data, so on data that contains information for every single patient, which is registered within the National Health Services. So this is in England, but this type of formula in different way, perhaps with different objectives, are also used, for example, to inform the payment system for insurances in the US, or they start maybe being used, for example, also in some African countries. For example, I think in Ghana and Tanzania, where they've got national insurance in place at the national level, and they're starting to get some data. There's some example of use of those person level data to inform some of the allocation of funding and the payment system. One of the key things within those resource allocation formula is how to estimate service need. And this has broadly been done in two ways. One is just by looking at the prevalence of different diseases, and this tends to be in cases where there's resources that are allocated for a specific disease. So we have decided how much funding is going, say, for example, for mental health or for anxiety and depression, and then we can get a measure from the data about how prevalent this condition is across the country. Or in other cases, need has been measured as a general estimate of service need across different types of services. And this is, for example, the way in which it is done in the UK by using a slightly more complex risk adjustment model. And this is the example that I wanted to talk through very briefly, not as much to talk about England, but just to give an example of how person level data from administrative record can be used or are used in some setting to inform the distribution of budget. So we are in England, we are thinking about mental health. There's a rich data set which is not accessible to everyone and not accessible for research, but is accessible to NHS England that managed the provision of services and the allocation of budget. So imagine you can have data where you've got one row for every single person or single adult in this case, which is registered with the National Health Services. So we are talking about 43 million people. And then by merging information from different data set that covers the use of different services, you can then have some information on the total use of mental health services. And you can aggregate the use of different services by weighting that by the cost of specific services. So for example, imagine you have a person that attend a certain number of outpatient consultation, you can cost them up with relative cost. And then if they also have some maybe inpatient stay, you can cost the inpatient stay and add everything up for that. And then, so we've got this rich data set, job information, we've got information on the total use, accounting for different types of services, but then we also have some information on every single person, mainly on the demographics, including age, gender, ethnicity. In some cases, for example, there's some information that is derived about the household type where the person lives. So if they live alone, if they live with other adults or children, and so on. And then there's information about diagnosis, both from mental health, but also from other diseases that are derived from a number of different data sets, which I've listed there, for example. And then there's a little bit of statistical analysis, which is done, and this is the base of, I think, any risk adjustment model. And this is a very simple explanation, but it's you can think of having the total service use expressed as the total cost for those service use, and analyze that as a function of individual characteristics that capture the needs for services. That might be the demographics, ethnicity, the household types where the individual live, plus some area level characteristics that can capture needs. And this might be, for example, whether the person lives in a more deprived area, whether the person lives in some sort of environment that might be more stressful for a number of reasons. And then some area level variables that tells you something about the availability of services in that area. And that might be the distance from the provider, that might be the type of services for mental health or maybe for other services that are available in the area. And then generally, because services are hierarchically organized, there's some accounting for the fact that all of those people maybe live in the same administrative area where services tend to be provided in the same way. So you've got all of this information, you can estimate this regression, and every coefficient in the regression essentially gives you the relationship between this set of need and supply variables and the cost. And then from there, this information can be used to get a prediction of the cost. But one of the things that is done in England to try and account for the fact that in different individuals in different areas might access services in a different way, and that might affect their utilization. When doing the prediction of the cost, the effects of any of the supply variables, so the availability of services in the area and the administrative area in which the individual lives in, is sterilized. So the prediction is made by letting the expected use and cost of use vary depending on the individual level and area level variables that capture need, whereas everything else is set fixed for everyone across the country. So every difference that we can observe in the predicted service needs for individuals is then related to characteristics that we would expect to legitimately affect service need. And again, this type of model with maybe more sophisticated functional forms or econometrics is basically the base of different risk adjustment models that are used around the world, or for example, by insurance scheme in the US as well. But one of the things that might differ is whether there is this sterilization of the supply effects, but sort of the mechanics of the model otherwise remain the same. And one of the main things that become also somehow a policy decision is which type of information has to be included in this type of model. So what do we expect? And we recognize that would be a legitimate factor affecting the needs for services. And I think it's really nice, the presentation that we have just seen, that tells us that there's clearly some factors at the individual and household level that affect the prevalence of mental health. So we would maybe expect all of those to be legitimate determinants of service need. But again, the choice depends very much on what is relevant for a specific setting, what is the policy emphasis, and also ultimately also by what data are available and what are the limitations of the data. So from this is just to wrap up the presentation of the model and say that then once you have estimated the service need for different individuals, then you can group them up by different geography that are relevant for the allocation of funding. So for example, in England, it was the clinical commissioning group that is basically the unit that administered the provision of services locally. And you can derive some indices whereby you divide the predicted need for that group by the national. So when the index is higher than 1, you have an area that has a need which is higher than the national average, and 1 is low, that need is a bit lower. And you can then use that index as a weighting for the population in the area and derive share of weighted population that can be used to inform the distribution of budget proportionally across the country. So before getting into the potential and limitation of the PPGS specifically, I thought it would make maybe sense to think about what are the potential and limitation of this type of model and this approach to resource allocation that in a way very much depends to the data that are available, but there's some, again, potential and limitations that are quite common across models and across countries. So one of the main advantages of this is that because they're done on administrative data, those models potentially account for everyone that is owed to receive services, and they allow us to use information on their demographic characteristics. one of the advantages of this type of model on this type of data is that somehow we basically get out information from all the decisions that have been made by medical practitioners and have been recorded. So we don't really have to make many assumptions, but somehow we get information out by all decisions that have been made by medical practitioners that presumably would know more than an economist maybe about which specific care a specific individual needed at the time. The advantage of this type of model is that we can attribute to individuals a service need based on a combination of characteristics that they have. So not only based on the prevalence of the disease, but also a number of other factors that affect generally how much they would use or need services across. And also one of the advantages is that we can also account for the effect of multimorbidity. So we're not looking at the prevalence of one condition alone, but how the prevalence of that condition plays out alongside other condition that we can include in the model. Another advantage is that we can also compare individuals with different characteristics by using the same metrics. So again, if we think about individuals that lives in very different area or that use very different services, for example, we can still compare them and join up the information and get to a number that can help a government to allocate an overall budget when that budget is not allocated for any specific service in particular, but for the whole set of services that a place ought to provide. And then, as I was trying to show by explaining this exercise that is done in England, again, I explained that in a very simplistic way, but then the idea there is that there's some econometric method that is applied to try and account for the fact that what we observe is driven not only by differences in need, but also by differences in the present availability of services across different areas. And ideally, we don't want to account for that. So that's some methods that can be applied to get around these issues, but they're not perfect. Some of the downsides when we think, for example, about need, or when we think about some information that we can get from survey data, then again we can see that those models, because they're based on administrative data, really they don't account for those individuals that don't use service. So if someone is not registered with the NHS, or in the case of Indonesia, is not covered by health insurance and that doesn't show up in the data set, their needs are not really accounted, where ideally we would really be able to account for the needs of those people and reach out and provide services to them. There's also a limitation in the fact that we only account for needs of those services that are recorded in the data, and many times providers end up doing a bit more that doesn't really show up in the administrative data set, maybe to reach out to some more disadvantaged population, and this doesn't show up. And also one of the simplification that I think is quite common across models is that there's one single cost that is applied to every single individual, whereby individuals might live in different circumstances, and providing the exact same services to different individuals might require maybe more time, might require maybe translation, might require maybe reaching out to the people, and this might have a different cost, but those different costs are not really accounted. And then there's lots of sensibility in the data, in the way in which different providers might record condition, individual characteristics, or service use as well. There's a big limitation in which some information that is important, and we have seen that in the presentation from the survey, such as income, or maybe like education or marital status, might not be captured administrative records, but they play an important role in for example, predicting mental health prevalence. But again, the strength and the limitation of this type of models depends very much on the data that are available, but also on the institutional settings and the objectives of the models. When it comes to the BPGS data, I think we're going to hear a bit more in the next presentation, but it's just to remind that I think the Social Security Agency for Health started operating, I think, in 2015. And since then, this means that there's also data collected at the national level on the registration with this national insurance scheme and on the use of services under the national insurance scheme. Couple of things that are important in thinking of how to use this data is that the participation is mandatory. And this means that in 2023, about 255 million of people in Indonesia were covered. The coverage and the registration is essentially by household. So once one individual is registered, the whole household is covered. There's a premium to pay, which is about 5% of the monthly salary for workers. But that is also subsidized for the poor and disadvantaged population by national or local governments. The service covered, broadly speaking, include primary care, health promotion and prevention, and then the referral to secondary care, being both inpatient or outpatient care. They also cover emergency care, and there's a bit of a compensation that is given to individuals for remote care, being that having to access services from far or being that accessing services online. One thing to note is that for the inpatient services, there's three different class of services that cover inpatient stay in different types of wards and obviously have a different cost. Would say a couple of things about that later. The data is obviously national, but is obviously massive because we are talking about 250 million of individuals. So one of the great things that has been done has been to create a sample data set from the individuals registered with the insurance. And that started from 15, 16. And then we have observation for 17, 18, 19, 20, and then 2021. That data set cover about 1% of the registered population, is a longitudinal data set and anonymized. It is representative of the national, provincial, and district level, but at the district level, the sampling is done by health facility, and then within health facility, there's strata that are determined based on where the individuals and their family have had contacts or not with the care services. There's not really attrition in the data, and the death of some individuals and the fact that they might not be active is also recorded in the data set. The data set is organized in 5 parts. There's one data set which covers the demographic information of the registered patients. There's 2 data sets that cover primary care service use, and one is related to the services that are covered by capitation payment, and the other one is related to the use of services that are covered by non-capitation payments. And then there's 2 data sets for the referral to secondary care, one that covers the actual visits, including outpatient and inpatient stay, and the second data set that includes the secondary diagnosis related to each of these visits. This is a very brief picture and overview, but again, my colleague Alpha is here if there's more specific questions, and maybe more will be covered in the next presentation. But when we look in the data set, what we can see is that so if you can see that in the top row, the number of COVID individuals has increased over time from 15-16 to 2020, and that has increased from about 171 million to about 222 millions. And then if you go on the very last row, you can see that the sample is covering 1.7 million in 2015-16, and then more households and individuals are added every year, and that sample gets to cover about 2.2 million individuals in the last year. So it's quite large data set and quite comprehensive. When we look at the number of individuals that have been in contact with services, in the registration data set, there's also some information about individuals that have access services or not. And this is used for the sampling frame. But basically what we can see is that of all the registered individuals, there's about 63% that has been in touch and actually recorded as having used services under the scheme. And this is proportion is lower a little bit over time. And part of that might be due to the way in which the sample has been increased. The membership dataset contains information about the demographics, the province or district of residence, the type of provider in which the person and their household are registered. And then there's also some information including regarding the membership segmentation status. So what type of insurance coverage they have and which class they're recorded in. So just a couple of words about the class, and to say that, for example, the inpatient ward class 3 were mainly people who were not salaried, and those were people who would have been in an inpatient in larger wards. And many of those in class 3 are also individuals that are subsidized by central and local government, whereas salaried workers tend to be in class 1 and class 2. So this is an indication that this information can be used as a proxy for individual income. When it comes to the primary care dataset, capitation and non-capitation, but you've got here in the slide some information about what are the main diagnoses that, for example, for capitation, they tend to cover respiratory infection, common cold, hypertension, some form of stomachache or myalgias. And then we can see that about 20 or to 30% of registered patients were varying across time, were in touch with primary care services to receive services that were covered by capitation. And the number of consultations varied between 2.7 to 3.9 for those who had been in touch. And it's important to know that it is only 10 conditions that seem to lead mainly to 80% of the referrals from primary to secondary care services that are recorded in here. Non-capitation, the use is much lower, so it's only 2.3% of the individuals that make use of those visits, and delivery ante and postnatal care tend to be sort of the main treatment that persists over time, and then there's some other conditions that affect the use. When it comes to referral care visits, then it's only 8 to 10% of patients that are registered that make use of those services, and they appear to have either some between 3.19 and 4.69 visits each year. And one of the things to note is that in terms of the primary diagnosis, there's these factors influencing health status and contact with health services that are paid to cover 65% of those visits. So there's something to investigate there about how the primary diagnoses are recorded and can be used. There's also some information on the tariffs that can be used to cost up those different services. And from this, from the primary care use data set, you can see that there's lots of variation, broadly speaking, in terms of access to services from primary care across the country. And obviously, in the eastern part appear to have lower utilization, which might be related either to lower coverage or to lower availability of health facilities. And there's a little bit of variation also if we look at anxiety and depression diagnosis reported in the data set. But I think this will be covered in more detail later on. Sorry, I'm running a bit over time, but I think I wanted to say that, again, some of the points that we discussed before in terms of potential and limitation for those models that use this type of secondary data remain applicable to using the BPGS. But then when we look at the BPGS in particular, again, we can see that there's all the demographic informations that are reported there. There's some interesting characteristic that is reported in the demographic data set, which is the marital status that, for example, is not commonly reported in data sets in other countries maybe, but might be of interest here because we have seen that is highly associated with the prevalence of anxiety and depression. One of the things that was striking to me is just to think that I think this is possibly the largest person-level data set on health services in the world because of the population in Indonesia, but also because this is one single insurance provider recording all of the data. So, for example, similar insurance scheme and data collection are taking place in other countries, but the insurance is more fragmented across the country, so data are not joined up. So this is, I think, a massive resource and potential that should be exploited further. There's the potential to link those data with other information at the district level or the area where people lives in, but from what I've understood with other administrative records, maybe in the future with a bit more work. One of the nice things that does not always happen in all data sets is that these include primary and secondary care for all individuals, whereas in some countries, maybe data sets are a bit fragmented and report information about specific type of services. This is, for example, the case in England. And what is also very nice is that there's information that is longitudinal and can track individuals across. Some of the limitations
Laura,
that
maybe for 4 minutes, another 4 minutes, please.
One of the things I think we should pay a bit more attention is that the coverage is not universal, and we have seen that there's a big difference in urban and rural areas. That the sampling is done by health facilities, so the data that we have might not be necessarily representative of the population at the district level. There's no reporting of private services that are used, but not that are used by individuals, but not covered by or reimbursed by the insurance. And then some of the utilization or cost of services might be affected by the class in which of the insurance in which the individuals are in. There's definitely a pinch of salt that should be taken in using information about diagnostic. And for example, when we look at the prevalence of recorded diagnosis for anxiety and depression, that is way much lower than what came out in the surveys and you have seen before. And then again, just a reminder how those limitations affect the analysis that we want to do depends very much on the objectives. And I think I leave it there, sorry.
Our presentation based on some data of the financing of the JKN and some of the claim data that Alpha has been supporting to produce, but I just pick a few data just to explore this to go, as Laura mentions, to explore what the opportunities and the drawbacks of using this data for larger policy making, for example. Next slide. Next slide is basically just a disclaimers. We use this and some of the comment is just my personal comment on this, my kind of judgment of the data. We at this time just explore to see to what extent that the mental health services for JKN members in the one plan JKM are quite reliable for decision making. Yeah. We have to also consider that this data taken from 1% claim, although the 1% claim data was designed to be representative of the population, but when we look at the low prevalence or low utilization of mental health services, the data of 1% might not be representative for the general conclusion or generalization of the result. That must be taken into consideration when we see the data. Next slide. I think also just to give our colleagues in this participation kind of idea how important is mental health care and or mental health services. I just quote one of the studies published about 3 years ago. Mental health is not only as part of the medical problems, it is also economic problem. This paper, the editorial on the global health, the Lancet Global Health, estimating that the anxiety and depression cost the global economy $1 trillion each year. So it's huge money, $1 trillion, and it is estimated that by 2030 it could reach $6 trillion. So if you look at the time frame from 2010 to 2030, within 20 years, the cost of the global economy increase 5 to 6 times. That estimated, that's the modeling. However, if we assess the situation that leading to mental health all over the world, it could be not much different by 2030. Next slide. First, I would like to also touch a little bit the reasoning of this important of mental health care or mental health services and the insurance. The first issue that mental health services or healthcare normally require long episode of care and costly, especially for those who have relatively serious or severe disease. Few individuals could not afford, could afford that one. Majority will not affordable for the common people, and therefore some kind of public insurance, the public insurance or health insurance can be in the form of national health services like in the UK. That's also in a way it's insuring and reducing uncertainty, increasing the financial protection when people need healthcare, especially for this mental health care. And also the best way of ensuring equitable healthcare for all, because if people already covered, fully covered, then certainly much fewer barrier to get access to healthcare. If this is one issue that we will touch, if the providers, the supply sides are ready or adequate. In addition to that, for the mild cases, maybe people don't see it, don't feel it because the symptomless. That's the issues on the mental health services that commonly understood here. And we want to see whether the JKN members utilize the coverage, the JKN coverage. Yeah. Next slide then. First, just briefly, Laura already touched a little bit. We just want to just touch a little bit that our national insurance designed to cover all healthcare needs. In the law, we describe that the benefit package is medically necessary, as long as the medical science confirm that this kind of situation need healthcare, need drugs, need diagnosis. This should be covered. So that's the design of the JKN. We don't have any specific listed benefit package in the JKN. And therefore, to be able to deliver those medically necessary services, the system use the payment to healthcare providers, both public and private, using the risk-based payment, and certainly require some utilization management to ensure that the services really needed medically, and not to much consume or less than consume. The administration by BPJSK is a public entity. Many people still in Indonesia still not aware about that. So they think that the BPJSK is similar like a private insurance company, the corporation that takes some profit for that. It is not. It is a public entity as a government, so not for-profit organization. As Laura already mentioning, is that contribution is 5% for the formal sector, for the wage earner, but until now it's limit to maximum the ceiling 12 million rupiah, Indonesian rupiah salaries. It is being proposed to increase to higher than that to ensure more equitable contribution. Yeah, otherwise, it is regressive because the burden for the lower income actually higher than the higher income who had above the ceiling. As also been discussed, the subsidies currently is about 40% of the population by the national government, and around 13% by the local government subsidized, mostly those who are non-wages and or self-employed people or informal sectors. Yeah. Next slide. Yeah. This is the current situation for the end of 2022, where national health accounts already having identification how much the share of the national insurance in terms of the total health expenditure to the total population, which is covered 95%, 250, 260 million people. But if we look at the share of the expenditure, only 21.7% in 2022. That's data indicate that there are discrepancy. While population coverage it is, I wrote that as registers, not covered, because the term register meaning those people are registered, but it doesn't mean that they are covered. It can be many issue. At this time, the data showing even in up to November 23, around 50 million people in the informal sector or non-wage earners fail to pay contribution monthly, and therefore their membership considered inactive. Yeah, and therefore the real financial protection of the population still not clear. We don't know. But certain for clear that the national insurance already reduced out-of-pocket payment from 45% in 2000 to 31% about a year ago. Yeah. So the still 30% is still above the WHO benchmark of 20%. So Indonesia still have to go a long way to achieve the optimum coverage to meet the universal health coverage goal. Yeah. Next slide. Yeah. So this is the indication that the system, although as I explained before, not all people who are registered actually utilize, but from the data, even last year, this is the 11-month payment of claim by end capitation, the down graph showing the capitation payment and the non-capitation payment for the primary care, and the above graph is the hospital claim payment that's increased from 9 trillion rupiah in January. We have new tariff applied in February 2023, and we can see by November the monthly claim has increased about 30%. Yeah, it's quite high increase. That because of the improving access. There are more healthcare providers contracted, and within the healthcare provider contracted, more services are available for the people, and therefore increasing the access. Next slide. In terms of financial situation, until recently, I think this data showing by November, 2 months ago, the fund, the asset of the JKN, the fund, the National Insurance Fund, still quite high, with 92 trillion rupiah. It's equivalent the situation in December 2022. So with the increasing tariff last year, so the JKN is still able to be sustained and keeping some money solvent to pay the claim. What about the mental health services? Well, in terms of the money available, it is affordable. However, other factors might not be good enough to cover everyone who need mental health services. Next slide. Yeah, if we look at the risk status, or we just also presented the prevalence of mental health problem, anxiety, depression, which is around 6 to even higher than that. How good is the JKN provide services to the member on these mental health services? Let's take a look just briefly. We will do more in-depth research later on. This is just to give you a brief outlook. Next slide. So here the distribution of mental health visit to primary care, yeah, the FKTP we call it, of this sample. If you look at the trend, unfortunately, this data is not a rate to the population size, just a proportion of the patient of the total 1% data of the primary care visit. The first all FKTP visit, that's 1%. So meaning that if we look at if we want to know the real number, we can do it basically by using weight. But other than that, we just multiply by 100 because this is 1%. So, for example, in 2020, the total visit in the primary care is 230 million visits. Among that, we can calculate all mental health visits can be 11,000 on the column of the 2020. Just look at there, 11,000 multiplied by 100. So that's basically it's about 110 visit. That's increased from 2015 about 4 times more. Yeah. But the total number of the population also increased. In the 2015, the total population registered was 110, increased double, and the visit of the mental health increased quadruple. So it seemed that the services or mental health services access increasing quite significantly, considering that the total visit increased quadruple, while the people register increased only double. If we look at the proportion to the total visit, that's only range from 0.4% to 1.6%. Still relatively too small to compare to the prevalence of the risk assessment data of 2018. Yeah. So the question is why the services of the mental health not as high as the prevalence as some surveys found. Yeah. So that's a big question. The factor might be cultural barriers. People might have some stigma if they know they are primarily or themselves suffering from mental health. They didn't use it, or they might be too far from their home, or there might be some supply readiness. There was no mental health doctor or psychiatrists in the facility, and doctors in the clinic might not be also well trained or competent to handle mental health care, and therefore the diagnosis might not be appropriate. So there's some issues in there. Next slide. If we look at the distribution by gender, we can see more patient. This is accumulative data of the 6-year data. Male tend to have higher utilization. It doesn't mean that higher prevalence, but higher utilization. Why the factor? It is still need to be explored. If we look at, I just gave some snapshot by highlighting with yellow on the class 3. The class 3 population is actually 70% of the total members registered. Yeah. But if we look at this proportion of the mental health services, only 52%, while the class 1, class 2 or about the same proportion. That's mean there's still over utilization or relatively above utilization, above normal by class 2, class 1, which is higher income, and class 3, lower income level. So that's still discrepancy in access on the outpatient at the primary care level, but at the referral level, there might be different. Next slide. Oh, yes, this is just kind of adjusted the proportion. Again, I just snapshot and pick the lowest level, the class 1 to 3. On the bottom, on the pie chart, showing you the distribution of the members of the JKN based on the dashboard of the National Social Security Council. You see here, the green one is the proportion of the people who have the entitlement on the third class hospitalization, the blue one, the second class, and the red one, the first class. So 71%. So if we can adjust that one, meaning that it is below the proportion. Yeah, we can do better with the rate per thousand or per 10,000 members of all those utilization later on. Yeah, to see how equitable the access to these mental health services. Next slide. If we look at the referral care in the hospital, we can see this is also data on the number of referral visits, both outpatient and inpatient together combined. We can see also depression and anxieties contribute relatively small numbers, small proportion. The burdens for the healthcare providers might not be big. But this is also, again, might be attributable to the fact that our psychiatrics specialists, maybe Irmansa can comment on this, might not be good enough. Since this is national data, we can assume that there's still a lot of barrier because of the supply not ready, not available. So in that situation, then recommendations certainly taking the Laura's thinking, how do we utilize this data to have a good plan to distribute psychiatric services or mental health services across provinces. Yeah, so this is just showing the data that might not be good enough. Yeah. Next slide. If we look at the also the inpatient, outpatient, the proportion of class 3 is relatively good. So this is another question, why in the referral level, relatively higher proportion of the lower income utilize the referral care. I don't know the answer, maybe from our primary data collection, some answer can be revealed. Yeah. If we look at the outcome of the services, 97.2% discharged with healthy, only 0.3% deaths. That might indicate good quality. I don't know. We have to compare with other diseases, or maybe this indication that the mental health care problem might not be so severe. Yeah, we don't know because we don't have population-based data. Basically, this is a claim data that might be biased to only those people who utilize the services, excluding those people who opt out from the services, from the coverage. Next slide. So again, this is the distribution by others characteristic. We can see marital status and so on. I think I just skipped that one. We are already close to 6 p.m. here. Next slide, just to show it. So just the discussion, preliminary look at this distribution demonstrate low utilization. That's, I think, my conclusion, looking at comparing at the prevalence rate based on the IFRS, Riskus Das, or other, even the primary survey. So then the big question then, can we use it for our planning purpose. Certainly, in some way, with some limitation, we still can do it. We still can use it. And one of big lesson from here is to ensure that the claim data will also must be also accompanied by the appropriate people data, the membership data. Yeah. It is possible, maybe from the qualitative studies, we can also have some information how good the members, the people suffering from mental health services, aware and want to use, what kind of stigma. I think the expert opinion important here to complement the finding to be able to generate a good recommendation to ensure that mental health services are provided equitably across different provinces, across different population characteristics. Certainly from the data on the other data, unfortunately, this is not available in the JKN or the BPJS data, but it can be found from the supply side data, that supply side readiness or availability in many provinces are inadequate. Certainly with that, inadequate human resources, inadequate facilities, the utilization will not be accrued. Yeah. Transportation and distance in many provinces in Sumatra, Kalimantan, Sulawesi, even Papua are the big factors that inhibit people to utilize mental health services. Yeah, I think that's Ayana. Hopefully it can generate some question to be explored. Thank you.